Hello and good evening, everyone. This is BlueHealth's virtual seminar. BlueHealth's virtual seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by BlueHealth Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO at BlueHealth Ethiopia. Today we have Dr. Ayalew Zewdie here with us. Dr. Ayalew is an associate professor of emergency medicine and also an editor-in-chief of Pan-African Journal of Emergency Medicine and Critical Care. And he is going to give us a presentation on the sudden cardiac arrest versus sudden death.
Thank you for the nice introduction. Hello, everyone. So today I will take almost around 90 minutes. I hope we'll have a good discussion and interaction together. I hope everyone is a health professional, so I hope you will understand what we are going to discuss. So anything question you can raise, and we'll try to make it more of interactive. So before I start, I don't have any disclosure to raise, and the objective of today's CM is, the first one is to explain sudden cardiac death versus sudden cardiac arrest, and to review the different causes of sudden cardiac death and sudden cardiac arrest. And lastly, we'll see the main treatments for a patient with sudden cardiac arrest and sudden death. So before we start, I think we better discuss what's heart attack versus what's sudden cardiac arrest. Maybe we start. Could you write in chat box what do you mean heart attack? What do you mean by the sudden cardiac arrest? I'll give just 30 seconds. So let's see your active participation here. So what is heart attack and what is sudden cardiac arrest? Can you hear us? Adam?
Yeah.
Okay.
Yeah.
So it's no audio. Someone says no audio. Okay. Getachew says heart attack. MI. Someone says heart attack is when the heart is not getting enough blood supply. And heart attack is occurrence of cardiac ischemia. Heart attack, MI. What about sudden cardiac arrest? Cardiac arrest is when the heart stops contracting. Heart attack, Dr. Tamana says heart attack is MI, but sudden cardiac arrest is loss of heart activity of the heart. Cardiac arrest is unexpected loss of heart function. Okay, thank you everyone for your participation. So as we mentioned, heart attack is almost equivalent to acute coronary syndrome. So it's a syndrome by which there is a circulation mismatch for the heart. It's mainly affecting the coronary circulation. So there is a demand and supply mismatch with a patient present with acute chest pain. Whereas in a sudden cardiac arrest, it's mainly the stoppage of the heart beating. Yeah? So it's stop the function of the heart. That means it's mainly beating. If the heart stops beating or is not beating sufficiently to maintain the perfusion and life, it's called sudden cardiac arrest. Whereas sudden cardiac death, it's defined as the unexpected natural death which occur from the cardiac cause. It should be within a short period of time. Generally, it's recommended to be less than 1 hour. from the onset of symptoms. So in a patient without any prior condition that could appear to be fatal. So I think, most of the time people say he's fine, he was okay. Even he was talking to us, he was eating well, we have dinner together, and then he suddenly collapsed. And then in such histories nowadays is becoming really common. So these two terms are used sometimes interchangeably, but the main difference between sudden cardiac arrest and sudden cardiac death is if the patient survives after resuscitation is called sudden cardiac arrest, whereas if the patient died after the sudden cardiac arrest is called sudden cardiac death. So the difference is mainly about the outcome. And so patient who survived after the cardiac arrest is called sudden cardiac arrest survivor, but if the patient died, then we call it sudden cardiac arrest or sudden cardiac death. So let's see the epidemiology. So different studies shows in the Western, epidemiologically it's a very common, and it's closely related to the coronary artery disease, which is mainly responsible around 75 to 80% of sudden cardiac death. In the estimated around 180 to 300,000 sudden cardiac deaths occur in US annually, which is really significant. And worldwide, sudden and unexpected cardiac death is the most common cause of death, which account for 17 million deaths everywhere, with sudden cardiac death accounting around 25% of this. So what about in low and middle income countries? What's happening to sudden cardiac death? So as you know, sudden cardiac death is unpredictable, okay? And it's very difficult in low and middle income countries to exclude the non-cardiac causes of sudden death. And then lastly, the application of definition is very difficult. I hope everyone knows about the death certificate in our setting, where people write at the end of the day, like, he died cardiorespiratory arrest, okay? Everyone says, immediate cause of this cardiorespiratory arrest. So it's very difficult to say people died because of sudden cardiac death, since we can rule out non-cardiac cause, and then everyone, the summary says cardiorespiratory arrest, like that's the end goal of everyone. So it's very difficult to predict and to determine the epidemiology of low sudden cardiac death in low and middle income countries. So how should be this assessment should be done, like the surveillance system? So sudden cardiac death surveillance, it's originates from different sources. So you will have verbal autopsy, medical records, or sometimes from the pre-hospital, the emergency medical response system will provide different data, okay? So that means from the community, from the health community worker, from the hospital, even health centers, and the emergency medical response system, that is the pre-hospital system. These different data will be verified and then assessed to determine sudden cardiac death surveillance. So what happens to our country? Do you have any study? So I tried to search, and then I get one study in 2001, which is done in Menelik forensic. They assessed 92 dead bodies in 3 groups. So the first one, group A, is those having the heart is showing adequate morphological change, which will explain sudden death. It's around 63. From 92 is 63. From this 63, coronary artery disease account 44 cases. The other is excessive myocardial hypertrophy due to post-traumatic valvular lesion, is around 7 cases. The second group is group B. The heart is showing some structural change, but it's inadequate to explain sudden death, which is around 20. The other groups in which have a very normal heart having sudden death. So as you see here is almost comparable to the Western studies, that sudden death most of the time is related to coronary artery disease. But no study after that was reported. So let's come back. What are the causes then? What are the causes? So could you write some of the causes that will lead to sudden cardiac arrest or sudden cardiac death? The 30 minutes. What are the main causes that lead to sudden cardiac arrest? Math says coronary artery disease, drug overdose, atherosclerosis, MI, heart attack, 5H5T, P, trauma, electrolyte, heart blocks, genetic arrhythmia, toxins, myocardial hypertrophy, Brugada, genetics, drug abuse, embolism. Thank you. So mainly it is two types, the cardiac cause and non-cardiac cause. Now, based on the definition of sudden cardiac death, is mainly caused by cardiac origin. Okay? So from the cardiac origin, the main one is coronary artery disease, which accounts 75%. That's acute coronary syndrome or with complications. The second one is cardiomyopathy, different cardiomyopathies. Direct cardiomyopathy, hypertrophic cardiomyopathy, even sometimes arrhythmogenic right ventricular cardiomyopathy could lead to sudden cardiac death. The other is inherited arrhythmia syndrome, different arrhythmias. The main ones is long QT syndrome, Brugada syndrome, sometimes the catecholaminergic polymorphic BTAC. The other is early repolarization syndromes. And the fourth one is valvular disease. The other is different mixed components. So based on age, if the age is more than 35, then the main cause still persists. Around 80% is coronary disease. In patients less than 35 years, hypertrophic cardiomyopathy will be the common cause, which is followed by coronary disease. But in age more than 35 years after coronary heart disease comes hypertrophic cardiomyopathy. As you know, commonly in athletes, youngsters, hypertrophic cardiomyopathy leads to sudden death. So what happens? What's happening after different causes? Then this anatomical or functional substrate, like coronary artery disease, cardiomyopathies, arrhythmias, finally, the end product is to lead to different arrhythmia. But how this arrhythmia occurs? There are different transient events. Could be drugs, could be electrolyte abnormality, could be stress, could be ischemia. So based on these transient events, the four mechanisms of arrhythmia will have re-entry, automaticity, triggered activity, and block. The first three leads to tachyarrhythmias, where the block leads to bradyarrhythmias. So these tachy and bradyarrhythmias at the end will have four arrest rhythms: ventricular fibrillation, ventricular tachycardia, asystole, and PA, or electromechanical dissociation, pulseless electrical activity. So this is the main cause for developing sudden cardiac arrest. So the end product is the black one, almost the arrhythmia. So what are the risk factors? You know the causes, you know the definition, you know the pathophysiology now, and what are the risk factors for developing sudden cardiac arrest or sudden cardiac death? So let's have 30 seconds now. Just tell us the main cardiac risk factors for developing sudden cardiac arrest. HANA, dyslipidemia, diabetes, smoking, age, smoking, obesity. Dr. Tarrafa, it says hypertension, alcohol intake, hypertension, modifiable and non-modifiable, genetic, old age, male sex, smoking, pre-existing ischemic heart disease, congenital abnormalities, sex, channelopathy, familial, hypertension, DM already described, drug, male obesity. Okay, thank you. So these are the most studied risk factors. Smoking, maybe you can classify as modifiable and non-modifiable. Some of them are non-modifiable, but some are modifiable. Smoking, coronary artery disease, or previous heart attack, obesity, diabetes, hypertension, sedentary lifestyle, high cholesterol, old age. From the sex, male is predominant, stress, drug abuse, nutritional imbalance like electrolyte, hypokalemia, the like. These are the main risk factors that people lead to sudden cardiac arrest or sudden cardiac death. Sorry. So we have the upstream determinants, some of the substrates, and then the inducing factors. Sorry. So the upstream factors could be demographics, cardiovascular risk factors, genetic predisposition. So the demographic like age, sex, socioeconomic status, diabetes from the cardiovascular risk factor, smoking, hyperlipidemia, hypertension, and genetic. When these 2 or 3 things combined with different substrates will lead to into maybe coronary artery disease, or they will lead to left ventricular dysfunction, or they may lead to cardiomyopathy, or sometimes because of genetics or the like will have channelopathies, different arrhythmias with already mentioned different types. So this could be induced by diet, okay? Could be induced by drugs, could be stress or activity. So these all 3 things will end up in sudden cardiac arrest. So what are the clinical presentations for a patient with sudden cardiac arrest or sudden cardiac death? So let's have 30 seconds now. What are the main clinical presentations? Severe chest pain, shortness of breath, diaphoresis, chest tightness, syncope, bradycardia, shortness of breath, fatigue, palpitation, loss of consciousness, palpitation, confusion, restlessness, collapse, vomiting, sweating. Okay, thank you. So the main clinical presentation will be already mentioned: shortness of breath, chest pain, palpitation, dizziness, loss of consciousness. Anything could present before the arrest. So the arrest the patient could have will be unresponsive, no pulse, no breathing. So these are the hints: unresponsive, no pulse, no breathing. So when you find the patient, you will find him in the arrest condition. Before that, we'll have chest pain, we'll have palpitation, dizziness, or mentation change, the like. So what shall we do? What's the treatment? CPR, CAB, oxygen, treat the cause, anti-pain, CPR, defibrillation, high quality CPR, start A, B, C, D, E of life, call for help, ECMO, dopamine, cardiopulmonary resuscitation. PCI, defibrillator, risk modification, morphine. Prevention and follow-up, chest compression, resuscitation. Risk identification. Okay, thank you. So the four main aims, first is to identify the life-threatening condition and manage it. Okay, early resuscitation, workup and underlying cause, definitive management, and the preventive methods. So these are the four main aims while we are managing patients with sudden cardiac arrest or sudden death. So if the patient arrest in out of hospital, there are out of hospital cardiac arrest chain of survival. So the first out of hospital cardiac arrest chain of survival is immediate recognition and activation of the MS system. So how can you recognize, like if you, how are you going to tell the layperson or the bystander? How can the people recognize a patient is in a cardiac arrest? Can you write in the chat? How can laypersons identify a patient is in a cardiac arrest? Check pulse. You think they will check a pulse? This is in out of hospital, not in a hospital, in the streets, at home, for non-clinicians. Non-clinicians, how are they going to check if the patient is in a cardiac arrest? High degree of suspicion, breathing, heartbeats, position left side. So as a clinician, how are you going to tell the community to detect a patient is in a cardiac arrest? Cardiopulmonary resuscitation is a treatment, but breathlessness, okay, unresponsiveness, tell the patient name, educating. So how are you going to educate them? Call his name, check for responsiveness. Good. Okay, check for responsiveness, and these are responsive. What do you do? What's next? Raise WP for non-professional, less likely. Positioning, how do you position? What are you going to do after positioning? Call for help. Check pulse, still check pulse, no. Look for chest movement. What are you going to look? For the layperson, what are they going to look? Chest position, shock position, no. Call for help. We'll come to that. Call for help position patients. Check pulse for 10 seconds, no. This is out of hospital for lay rescuers who are not trained, who doesn't know medical terminology. Asking the patient any help. He's in a cardiac arrest. Call for help. Look chest movement. What are you going to look for chest movement? Mouth to mouth breathing. Then what? Bring your ear to patient mouth. Very difficult in the era of COVID. Team organization, responsiveness. So the first is unresponsiveness. Okay, the first one is check for unresponsiveness. So you call his name, you don't know his name, then you know, like Wandem Abat or somebody, like in our terminologies. So you call him or tap his shoulder. If there is no response, try to pinch, stimulate, no response, and then look for breathing. Okay, looking for breathing. That means, as somebody said, looking for the chest rise. You know, people could understand how when the patient or the people is breathing, the chest will go up and down. Okay, up and down. So looking for that, checking for responsiveness and checking for breathing is the two main factors that Levy square could identify. So if they get a patient who is responsive and no breathing, and then they have to activate the MA system. So what are you going to activate in Ethiopia? So let's start from US. What are you going to call if the patient is in cardiac arrest? In US, which number do you use? 911, 911, 911. Everybody knows 911. Okay, what if you are arrested in Addis? Where do you call? 939, 988, Tabita? Do you call directly Tabita? It should be a number or something. 939, what's 939? 939, what's that? 911, what's 911? They call me. From where? 911, 939, 8035. Where is 8035? 8035, where is it? Tabita 8035, 939 939 fire, does it work for cardiac arrest? Any ambulance, how help the patient? 8335, you call for God. 8335 to COVID. 939, call near Red Cross around Shashamane. Wow, how can you remember in a cardiac arrest this very long number? So when are you going to have one number? Like you mentioned, a lot of numbers, 939, 907, a lot of numbers. So this is a very big question for our health system. We need to have at least one common number. Even you get a number to call like 939, significant number of the calls are false calls. That means it's very difficult even to get an access. Okay, so it's very difficult nowadays. So we need to work on that. The health professional should fight and should work on having at least a one national number, which whether you call from Harrow or you call from Governor or somewhere else, you need to have a very strong connection, which even that should show the GPS, like people where the patient arrested. Even though you call for ambulance, how long it will take to come to you. Okay, so we are talking cardiac arrests. So you are going to start CPR, and then until you get an ambulance, how long it will take? Maybe if in Addis, like people call from CMC, around CMC, then ambulance station is around Piazza, then sometimes it may take 1 hour, like after the patient dead, and then maybe they come to take him to forensic, So we need to fight and then have an access for national having organized emergency medical service. So that is how the cardiac arrest will make a difference, will have a better ambulance. So sometimes we better come up with the local solutions, developing different applications, like Dr. Bina was mentioning different mobile applications to search, to localize, and the like. So let's start by identifying different one number. So the other is community education, how to recognize cardiac arrest. Then the next will be high quality CPR. So as you are buying different clothes, you need to ask, how is the quality? Does it come from different, is it from China? Is it from Taiwan? Is it from US? Is it from Germany? You will ask different, how is the quality? So as the quality of the cloth, then you need to have a quality of CPR. So it should be early, and then you should have high quality. So how are you going to have high quality CPR? Do you know the characteristics of different high quality CPR? Can you write some of the components of high quality CPR? Dr. Tamane, high quality means chest compression 120, 125 centimeter. Patient lie on hard surface, 32 compression. Rate hard fast, debs. Minimize interruption. Push hard fast, 30 compression to ventilation. 100 to 100 per minute. Place debs technique. Place debs technique coordination. Head tilt lift. First, you need to open the airway. Avoid hyperventilation. Duration, adequate recoil, coordinate. 2 to 15, pediatrics or adult. I'll look for obstruction, look adequate recoil. So push hard and push fast is the first one, okay? So where do you position your hand? The position of the hand should be where? People used to say, somebody says if sternum, lower sternum, okay, between the nipples. People used to say to the left side of the heart, left side of the chest. But nowadays it is lower sternum, okay, lower sternum. You don't need to go to left side. Okay, push hard. What does it by push hard? Should be the depths, okay, the depths. The depth should be 5, it says 5. But how are you going to know it is 5 centimeter, you know? How are you going to do 5? Are you checking from the side? Like now I'm in 5 centimeter. How are you going to check? In pediatrics, circular 2-finger, 2-inch. Now, how do you estimate? How do you grossly estimate? At least, yeah, one third of the AP diameter. Okay, 1/3. Okay. Rate, how much should be the rate? Push fast as much as possible. 100 to 120. What? 100 to 120. What happens if you go more than 120? What if you go more than 120, like 160? A really fast, a very fast one. Yeah, didn't feel no recoil, and then will be decreased blood volume. We interrupt diastolic refill. Yeah, so there should fill. So there should be time for filling. If you are pushing an empty heart, then there will not be any cardiac output. What if the heart will be what you are pushing very slowly, like 1, 2, very slow, around 60? What will happen? What will happen if you are very slow? Futile heart, no perfusion, decreased cardiac output. Why decreased cardiac output? Cardiac output is equal to decreased heart rate. Heart rate time, stroke volume. Okay, the heart rate is very low, then you will have a low cardiac output. Okay? Push hard, push fast. The other is minimize interruption. When are you going to interrupt? There are times that you have to interrupt. During defibrillation, good. Circulation mismatch every 2 minutes. Yeah, every 2 minutes for checking pulse and rhythm. Okay? Or checking pulse and rhythm. Other, when you the other for intubating, that's during airway check, intubation. You don't take time for intubation. Adrenaline, that's during pulse check, rhythm check. When you change race square, Yeah, you need to minimize changing during change. While exchanging. Other? Yeah, after confirmation of days or after you get ROSC. Okay. If you get ROSC, then you will already stop. Okay, next. The other character. Allow adequate recoil. Okay, they need to have adequate recoil. Other. What about ventilation? What will happen to the ventilation? Avoid excessive ventilation. Okay, Azad. How to avoid excess ventilation? So you give 30 compression, then to ventilation, non-intubated patients. Since you are talking out of hospital. Okay, Azad. So how do you compress Zambu bag? How much you compress? How much you compress the magma's ventilation or Rambo bag? Halfway. 50, around 50%. If you go more than that, okay, if you compress the whole way, that's happening every time. Like when you see like people resuscitating, like people will push everything. So because it is more than, some of the bags will go up to 2 liters or sometimes 1.5 in that bag. Okay, so it should be half at least. So based on the tidal volume. Okay. Good. So you need to read the qualities and then you need to practice. So practice will make a difference. Okay. So next is after high quality CPR is early defibrillation. So early defibrillation in out of hospital cardiac arrest, what do you think, what type of defibrillation is available? AED, what's AED? What's AED? Automated what? External defibrillation, automated electrical defibrillation, external defibrillation. Nothing in our case. No need of expertise. Nothing. AED, automated external defibrillator. Anyone who saw externally automated AED before? Anyone who used the AED before? Yeah, sometimes we lay square can use, but I haven't. Yes, for PEDS. So, okay, no. So, those who see the AED, where do you see that? Where do you get? Do you get in hotels? Do you get in embassy? Do you get in a bigger areas? Do you get in a stadium or somewhere? Do you get even in ambulance? Somebody says you walk hotels. I don't know which hotel. I don't want to mention names. Airport, airplanes. In abroad, you can't get everywhere. Yeah, in abroad, yes. But in our setting, in hotels, in the like in major areas, what do you get? Fire extinguisher. Okay, so it's the commonest. But we need to have, okay, we need to have availability of AED, and then please explain us AED. So AED is automated external defibrillator. So it works by applying the pads on the chest, okay? So the first thing that you do is you have the mannequin or the patient, then you have the AED machine. So that AED machine works by itself. So the first thing that you do, you just follow the order what was given by the AED. So when it says apply the AED, after you start it, you apply the pads over the chest. So the application should be the same as that you do defibrillation. So when you're applying the pads, one is in the right below the clavicle, and the other is on the left side over the apex. So the pad will be applied then you follow the order. So you just need to listen in English. Okay? So it by itself analyze the rhythm. It will decide whether it is shockable or non-shockable. And then it will tell you to move around or to be aside while giving a shock. So AED, which rhythm is shocked by AED? VFP, VT are shockable. VFib, VTAC, VFib, VTAC. Can it check VTAC? VFib, pulseless only. Pulseless VTAC only. VFib. Can it AED check pulse? No. So it's only ventricular fibrillation. It's only ventricular fibrillation that is shocked by AED because it doesn't analyze a pulse. So for lay riskers, we said there is no pulse check, okay? So you just apply the pad, you follow the command. If it is shockable, it tells you to stop the compression and then it can deliver the shock if it is only ventricular fibrillation. Yeah, as you mentioned, there are prerequisites while applying AED, okay? So one of the things is you need to have dry, or if there is moisture or water, you need to remove that. Oxygen, even though it's the hospital, then you need to remove oxygen. Okay, if there is pacemaker or patch, medical patch, then the application of the AED pad should be away from the site. Even sometimes they said hair should be removed because it will burn. Okay, you need to apply adequate amount of gel. Okay, adequate amount of gel. So we need to educate our community and ourselves how to use AED in out of hospital. So the other is advanced cardiac resuscitation. This is ATLS that the team of advanced team who is working in ambulance, the paramedics or the team from the emergency will go to the area, and then the advanced resuscitation will continue. After that, the post-cardiac arrest chain will continue in ICU or cath lab. So patients having post-cardiac arrest, having myocardial infarction, will need to go to cath lab, and the others who survive could also go to ICU. So what happens in our in-hospital cardiac arrest? What's the difference in hospital? So the first is surveillance and monitoring. So in hospital, you have a chance to, or you have the time to follow them, to monitor them, to assess them, who is going to die, who is going to have cardiac arrest, okay? So you need to do surveillance and monitoring. Close monitoring is really essential in hospital cardiac arrest. So the second one is activation of the core team, okay? So this core team is a team organized from different professionals who will be called during for the arrest area. So this team will have their equipment, their materials, or their bag, and then they go to the arrest area, and then they continue the high quality CPR. Then early defibrillation will be done. Lastly, the post-cardiac arrest care will continue. So as you see, the main difference here is one is the surveillance and monitoring is added here. If they are monitored, then they can detect the cardiac arrest earlier. There they call the EMS in out of hospital. Now we call the core team. And the last one is ACLS. It's already merged in the core team here. Okay, so these are the main differences in patients with in-hospital cardiac arrest and out-of-hospital cardiac arrest. So what has led to increased survival? What are the things will increase survival? Studies show like the main one is early CPR and early defibrillation. If a patient has ventricular fibrillation, every minute the mortality will increase by 10%. So if you get the patient after 10 minutes, he's dead. So every minute, the ventricular fibrillation mortality will increase by 10%. So you need to start CPR early, and then you need to defibrillate early. So that's why time is hard. The other things could be training of risk squares, okay? Effective CPR, early recognition, how to defibrillate. So even laypersons, even in a hospital, there should be training of the high quality CPR and others. So this should be practiced. There should be a plan, and then there should be practice. So the cardiac arrests will have different algorithms. In a hospital, we follow the algorithm. So it could be shockable and non-shockable rhythms. And then we'll assess the 5H and 5X. We'll see later on. So what are the main shockable rhythms? So before we go, let's identify the following rhythms. Let's start the first one. What is this? What is this? What is this rhythm? Asystole, asystole, PEA, asystole, PEA, asystole, 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 asystole. Okay, so most of everyone I think responded except few one says PEA in the line. So the answer is asystole. But this should be in a patient with cardiac arrest, okay? So the first thing is you need to assess the patient. This could happen if the cables or the attachments are loose, okay? Or is not attached, then you may find a flat line. So the flat line is called asystole. So this one is non-shockable. So let's go to the second one. This is a patient with no pulse. You see this without any pulse. PEA, 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 pulseless electrical activity, PEA. Excellent. So this is pulseless electrical activity. Any type of rhythm except the shockable rhythm is considered as PEA. So this should be in a patient without pulse. If this is the rhythm and the no pulse is called pulseless electrical activity. So now you have no pulse, and then you have this rhythm. What is this? VTAC, VTAC, pulseless VTAC, VTAC. Pulseless VTAC. Why VTAC? Why VTAC? Why do you say VTAC? Ventricular tachycardia. Why ventricular tachycardia? Why the QRS regular? Yes, why the QRS regular? Monomorphic. Tachy QRS, no P wave. Excellent. Narrow QRS, no. It's wide complex. Wide QRS. No P wave. Excellent. So this is a wide complex regular tachyarrhythmia. So this is ventricular tachycardia. So that's shockable. This one, what is this? BFib, ventricular fibrillation. Ventricular fibrillation. AFib, no, AFib. BFib. Wide polymorphic orsades. Do you think you will get pulse for this patient? If you get this rhythm and then do you think you will get pulse? No, you don't get pulse. So these, the two, pulseless VTAC and ventricular fibrillation are the two main shockable rhythms. Okay, so everyone should identify shockable rhythms. The other non-shockable rhythms are the asystole and PA. Good. So a basic life support. It starts from basic life support and then we'll go to the algorithm. So in basic life support, the first thing is identification. That is checking for responsiveness and breathing. And then you shout for help. And then you get your aid in defibrillator, check for breathing and pulse. You start high quality CPR and defibrillation. This is the BLS, the basic life support. Already we discussed that. So what is the difference between a manual defibrillator and AED? What is the difference between the manual defibrillator and AED? No rhythm analysis. I don't know which one. There is no rhythm analysis to Eros. We have to know how to read. God, which one? The manual. Okay, the manual. We have to know how to read. You know, we have to know the rhythms. AED, it analyzed by itself. Layer escorts can use AED. Millennium science AED does all the work by itself. Not all active, at least you need to start it. Okay, if you don't start it, it doesn't. And then at the end, it will tell you press the shock button. Okay, then you have to know how to press the shock button. Okay, yeah, it can guide you. You need to guide. AED analyzed by itself. So in the manual defibrillator, then we need to know the components, okay, the parts of the defibrillator, where to make it on, where to make it, how do you select the energy, how do you charge it, okay? And then how are you going to press the shock button, okay? So these are really essential. You need to know where is it monophasic, biphasic defibrillator, okay? Because the energy will be different. Okay, there is some terminology which sometimes will confuse you, like defibrillation versus cardioversion. So what do you think will be the difference between cardioversion and defibrillation? Write about cardioversion. What's cardioversion? What's cardioversion? Anyone? Can you write on the chat what's cardioversion? Cardioversion is synchronized shock. It's used for synchronization. Cardioversion is synchronized shock. Pulseless versus pulse. Defibrillation is for arrest rhythms. It's used less energy god. Cardioversion is for pulse, but defibrillation for pulseless. It will restore to regular heart rhythm. Which one? It will convert to sinus rhythm. Cardioversion. Yeah, synchronized cardioversion. We have to do synchronized cardioversion. Cardioversion patient should be awake. Cardioversion low energy shock to restore regular heart beat. So except the arrest rhythm, you do cardioversion. If the patient is what? What should be the patient condition when you cardiovert? Patient should be unstable. Patient should be, I will say, unstable. Medical procedure that is quick, low energy. So when you say the patient is unstable, so we are looking cardioversion for tachyarrhythmias. Okay, tachyarrhythmias. It could be narrow tachyarrhythmia. It could be wide tachyarrhythmia. Narrow, regular, narrow, irregular. Wide, regular, wide, regular. So the wide regular goes for defibrillation. The wide regular could be with pulse or without pulse. The one wide regular without pulse will go for defibrillation. The others, if they are unstable, you cardiovert. The cardioversion should be synchronized. So symptoms for instability signs. What are the instability signs? Chest pain, change in mentation, hypotension, sign of respiratory distress. Other? Anxiety? No, not for anxiety. Dizziness, no. We are talking instability signs, okay? The main ones. Chest pain, hypotension, intermental status, and pulmonary edema will lead to respiratory distress, shortness of breath. Why do you think we need to synchronize? Why do we need to synchronize? We have to do synchronized cardioversion. Why? Somebody says we have to synchronize. Why do you need to synchronize? Why don't you just cardivert? If not, we may cause arrest to avoid RONT phenomena. Good. To avoid change to torsade. So it will, because if it occurs on the vulnerable period, on the repolarization phase, then it will end up, worse arrhythmias. Okay, good. So let's look at the algorithm. So you start CPR, you give oxygen, you attach the monitor or the defibrillator, and then you check for the rhythm. So the checking for rhythm is recommended as early as possible. You don't need to wait 2 minutes to check for rhythm. Immediately after you get the defibrillator, immediately you better check for the rhythm. So if the rhythm is shockable, okay, if the rhythm is shockable, then you shock, okay? The shock, as I already mentioned, if you are using monophasic defibrillator, you use 360. So most of the machines are available in monophasic, but sometimes you may get a biphasic defibrillator. So you need to know your requirement. So you use a 200 to, you can increase up to 240. You for ventricular fibrillation or pulseless VTAC, you shock. Then you continue CPR for 2 minutes. Then you need to secure IV line, or if you have difficulty, secure IO access. Then you check for rhythm after 2 minutes. If still shockable, then you shock. Then you administer adrenaline. So adrenaline should be administered every 3 to 5 minutes. It's not every 2 minutes, okay? It's not recommended to give every 2 minutes. It's every 3 to 5 minutes. You can do it every other 2 minutes. That means every 4 minutes. Then you need to consider advanced airway. You may need to consider intubation. Or you can do capnography. So this capnography will even tell you how is the resuscitation. Okay? Then every 2 minutes, you pulse check, rhythm check. If it's still shockable, you shock. Then you will administer amiodarone. So amiodarone, how much should be the dose? 300. Excellent. 300 milligram. Okay. You administer 300 milligram. Then you treat the reversible cause. We'll see later. The 5H and the 5Ts. Then you go back. Okay. You go back. You continue. You continue the rhythm check, pulse check. If it is still shockable, you continue. You shock. Then you continue CPR every 3 to 5 minutes. You give adrenaline, and then you continue CPR after 2 minutes, pulse check, rhythm check. If it's still shockable, you shock, and then you administer amiodarone. Amiodarone, how much the second dose? How much should be the second dose? 150, okay? So the subsequent dose should be 150, should be halfway. So what if it comes to non-shockable? The non-shockable ones are asystole and PA, asystole and pulseless electrical activity. So you continue CPR 2 minutes, you secure IV line or IV access, and then you give adrenaline or epinephrine every 3 to 5 minutes. You need to consider advanced airway. That means intubation, capnography, then you rhythm check, pulse check every 2 minutes. If it is still non-shockable, continue CPR. Then you continue CPR for 2 minutes, pulse check, rhythm check. If no pulse, then still you continue this same cycle. Okay. So the asystole and PA, the non-shockable is really simple. Just continue CPR every 2 minutes. Then you give adrenaline every 3 to 5 minutes, and then look for causes for arrest. That is the 5H and the 5Ts. So what are the 5Hs and 5Ts? Wide hypovolemia, hypoxia, hypotension, hypoxia, other H. Hypoglycemia is out. Hypoxia, hypotension, hypovolemia, hypothermia. Okay. 5Ts. G trauma, toxins, thrombosis, trauma, why trauma? Tension, pneumothorax, yes, tamponade, yes. Toxin, tension, hydrogen ion, already. P. Okay. So the 5Hs are hypoxia, hypotension, hypo or hyperkalemia, hydrogen ion, that means acidosis, hypothermia. So these are the 5Hs. So you need to suspect based on the history. While you are doing CPR, while doing resuscitation, somebody should ask history, because sometimes you may not know the history, what's happened to the patient. You just immediately find him in arrest, immediately start CPR, you shock him, or if he's shockable, you continue CPR. While you are doing this, assign someone in your team to search for the possible causes. That a family should be communicated. How was the patient? Okay. You may tell you like people, he was vomiting, he was having continuous diarrhea or something, he was sick before that. Or they may tell you he had some kind of renal disease, then you may suspect hyper K or acidosis. Or they may tell you he was drowned, he was found in a ditch and then he stayed laying there for a long time. So you may think of hypothermia. Or people will tell you like he was coughing, he was having complete shortness of breath. So you may think of cause for hypoxia, and then you may treat. 5Ts, tension pneumothorax. So this could be spontaneous pneumothorax. If it's trauma, then that's another issue. Tamponade, cardiac tamponade. People coming with previous symptoms, okay, then end up in tamponade. Could be thrombosis, that means acute coronary syndrome. Could be P, okay, massive P, presenting in arrest. Even sometimes drugs or toxins. So you need to know the toxidromes. So communicating, taking history while you are doing the compression by assigning someone in your team, really essential. And then treatment should be done for each. If you're thinking hypotension, then while you are doing CPR, then fluid should be going on. Hyperk, you need to think of administrating insulin or other, hydrogen ion, sodium bicarb, hypothermia, warming the patient. Hypotension, tension pneumothorax, you need to do needle decompression. You need to auscultate, look for tension pneumo, then needle decompress, remove the air. You may consider chest tube, tamponade. So you need to do pericardiocentesis, okay? Coronary thrombosis may not be done at that time, but later on you need to think of PCI, pulmonary thrombosis. Sometimes, even though I have not available, thrombolytics can be considered. Toxins, antidotes could be considered based on the type of toxin. So what do you do after that if the patient get ROSC? Luckily, if you get ROSC, that means return of spontaneous circulation. How do you define ROSC? What's ROSC? What's ROSC? When do you say we achieved ROSC? Anyone? Return of spontaneous circulation. What is that? How do you know return of spontaneous? Yeah, pulse. So we gave pulse. Where do you check pulse? Where do you check pulse? Central pulse, okay? Should be central pulse. Central pulse. Good, should be central pulse. So after ROSC, so there are things that you have to do, okay? You can't leave the patient after you get pulse. you will not be happy and then leave. Okay, so you need to optimize ventilation and oxygenation. Okay, the oxygen saturation should be above 94, and then if you don't intubate him now, then now he should be intubated, and then you don't need to hyperventilate. Okay, you don't need to hyperventilate. You need to avoid hyperventilation state. And then if he's in shock, you need to treat the shock. You may give him bolus fluid, or you may consider vasopressor infusion. And then you could also consider treatable causes. Okay, it will continue. Then you have to do 12 lead ECG because, as already mentioned, the commonest cause is coronary artery disease, acute coronary syndrome. Then you need to do at least 12 lead ECG after ROSC. Then there are things that different trials considering induced hypothermia. If the patient doesn't follow command, then you may consider induced hypothermia. It's not common in our setting because it's not available to induce, because it should be targeted. And then you need to follow that. If the patient follow command, then if it's STEMI, you need to go to cath lab, and then coronary perfusion should be done. If no STEMI, then the other should go to advanced critical care. So one of the algorithms that after ROSC and after return of resuscitation, if it's really caused by arrhythmia and then previously documented arrhythmia, if it is bradyarrhythmia and reversible, then you eliminate the cause. But if the bradyarrhythmia is not reversible, that means if it is advanced dirt block, high-grade blocks, then you may consider pacemaker. But if the arrhythmia is tachyarrhythmia, and if it is reversible, then you treat the cause. If it's ischemia, if it is drugs, if it is electrolyte abnormalities, if it is supraventricular tachycardia, and then you treat the arrhythmia. If the tachyarrhythmia is not treatable or it's not reversible, you may consider ICD, implantable cardioverter defibrillator. This could be done if the patient has frequent shock. You may consider amiodarone. If the patient also refused or he can't afford for ICD, then you may consider amiodarone. If the cause is non-arrhythmia related cause, like if it's cardiac rupture, it could be hemorrhage, then it's surgical management. So you may need to work up with different things. So how are you going to work up in a patient with cardiac arrest after ROSC? What are the things you do? What do you work up? Exercise, ECG, yes, XCG, electrolyte, troponin, stress CG, CBC blood group is common, electrolyte, organ function test, echo, yes, electrolytes, ECG, bedside echo. So CBC chemistry, electrolyte, metabolic workup is mandatory. ECG is mandatory. Chest X-ray, echo, and angiography later on, MRI of the heart, toxicology screening, and sometimes they recommend even biopsy. So these are the standards they recommend in patients with sudden cardiac rhythm. They require biopsy. But now sitting at least we need to have the basics, lab investigation, CG, chest X-ray, echo, even up to angiography. So if you do ECG, there are different protocols. The one is a BART protocol. If the unexplained cardiac arrest is in the context of an obstructed coronary vessels, if the coronary artery disease is not the reason, then you do 12-lead ECG while lying, that means supine and standing. If there is different abnormalities, you look for that. Okay, look for that. Then you look the high-lead ECG for type 1 Brugada syndrome. Anyone who knows Brugada? What are the changes with Brugada syndrome? Sorry. Okay, Brugada. Sedentary syndrome? No. Is it a question? Okay. In younger, due to lithium. Okay. Yeah, still elevation. So patient will present with curved appearance of ST elevation from V1 to V3 with RBB pattern considered as Brugada syndrome. It's a type of channelopathy. So next you image and then echo or MRI is cardiac CT. If it is structural, you consider structural disease cardiomyopathy. Myocarditis, sometimes provocation testing, exercise or Ajmalin test. There is some drug called Ajmalin. You test them, look for this, is it longevity or Brugada or catecholinergic polymorphic BTAC, okay? And sometimes in Western, they do electrophysiologic study, genetic testing, cardiac valves. But at least we need to do ECG and then we need to rule out causes for channelopathies like longevity, Brugada, or polymorphic BTAC or repolarization syndromes, different arrhythmias. So let's test what this ECG, what do you see here? What do you see here? Anyone? Very fast. Patient is dying. What is it? What do you see? Brugada syndrome, electrical alternance, QT prolongation. Anyone? Brugada paced ventricle ST elevation. Only one person says QT prolongation. Tadasa. Why do you say QT prolongation? Okay, so let's come up. So this is a patient with QT prolongation. Okay, so you look for the QT prolongation. A very easy way is, so you look from the R wave to the R wave. Okay, then check for the end of T wave. So this is the end of T wave. So the normal circumstance, the end of T wave should be less than 50% of the RR. So it should be around somewhere here. But now the end of T wave is here. So this tells you QT is prolonged. You can calculate, you can count based on the QRS, and also you need to correct it, okay? So corrected QT over the radical of RR. But here grossly, it's obvious its QT is prolonged. So this patient presents with sudden cardiac arrest, and then post-cardiac arrest, this ECG is found. After few minutes, this happens. What is this? What is this? Anyone? Torsade, excellent, torsade. So that's a fear, okay? Patient with QT prolongation could be different causes. Most of the hypos, hypokalemia, hypocalcemia, okay? Hypothermia, drugs will lead to QT prolongation. But the other is genetic. There are reports on the Western, though we don't do genetic tests, there are genetic causes for QT prolongation. So this is the end product. If not detected early, or if you give him drugs or precipitants, then that will end up in the worst form of arrhythmia is torsade de pointis. Okay? Next, what is this? What do you see here? What do you see? Fast, fast, fast. ST elevation, lead 1, 2, and V2, be likely Brugada, banded branch block. Q wave and ST elevation. Good. I think so. This is likely Brugada. Okay, so look for V1 and V2. So let's start from V1. Okay, look the appearance of ST elevation. Okay, it's cove shaped like this. Okay, this is the ST elevation V1 to V2. Okay, then with the right banded branch block pattern, this is Brugada syndrome. Okay. So what are the other therapies in a patient with sudden cardiac arrest? The other is antiarrhythmics, or based on the causes, you consider medical therapy. The other is ICD, okay? Implantable cardioverter defibrillator. So this is for persistent, non-refractory ventricular arrhythmias, you consider ICD. The other is pacemaker for high-grade blocks, you consider pacemaker. Can you prevent it? Can you prevent it? Yes, no. Can you prevent it? Yes. Can you prevent it? Yes. So you do family screening. Modifiable risk factors can be treated. Okay, if you manage the modifiable risk factors, and then by doing family screening, these are the main mechanisms to prevent sudden cardiac arrest. So to conclude, sudden cardiac arrest, sudden case, the sudden death is still the public health burden worldwide, even though we don't know ours, but we hear like a lot of issues here and there. Early detection is crucial in the management of sudden cardiac arrest and sudden death, and early CPR and early defibrillation saves lives. So if you have questions, comments, then we can share. Thank you for listening and for your active engagement. Thank you very much.
Thank you so much, Doctor. I think this is one of the most interactive sessions that we had on our platform. So we have taken quite a few times. So let's pick 2 questions from the Q&A session. In the meantime, we will be posting the quiz since we are running low on time. Okay. So Doc, if you can see the Q&A session, please, you can choose maximum 3 most important questions from your view and address those.
Okay, thank you. So I just see only, there are 4 people, I think, but I think 2 say sorry. One is already the definition, and the last one is, can you predict sudden cardiac arrest? Even though you can't predict, but you can assess who is at risk and who doesn't have risk. So based on risk assessments, you can predict at least who will have sudden cardiac arrest, who will not have. So those different arrhythmias with different channelopathies, high likely if you don't manage them with single precipitant or multiple issues, then they will end up in cardiac arrest. So yes, you can predict and you can also prevent. I don't see any other question, I think.
Yeah, I think this is good enough. We are really low on time, so let's give them some time for the quiz. Thank you so much, Doctor, for giving such a long time for this amazing presentation. Everyone can, you guys can see the Telegram channels and YouTube channels written on the slides, so you guys can join and follow Dr. Ayalew's channels. So thank you so much, Doctor. If you have any last remarks that you want to mention regarding the topic or anything else, I'll give you the stage.
So no more comments. So thank you, everyone, and thank you also, Blue Hills, for inviting me. We'll learn a lot together. Thank you very much.